Welcome to our community conversation with the OHSU Center for Ethics in Healthcare. Our faculty leaders are going to be sharing the enormous challenges facing the healthcare system and how they are tackling these challenges head on. It is my enormous pleasure to introduce Dr. Susan Toll, Director of the Center for Ethics and holder of the Cornelia Hayes Stevens Chair.
Thank you, Liz. It's exciting to be here and to share new innovations with the Center for Ethics. I'd like to start by introducing Dr. Cliff Coleman, the inaugural Doris and Mark Storms Chair in Compassionate Communication. We hired him because of his international reputation in health literacy and clear communication. He has an MD from Stanford, a master's in public health from Portland State University. He coordinates the curriculum in the School of Medicine in ethics, professionalism, and communication skills. He's an associate professor in family medicine, and he is a primary care physician at a federally qualified health center. We look forward to his leadership and vision in the program in compassionate communication.
Thank you so much, Susan. I am so honored and so excited to be the inaugural Doris and Mark Storms Chair in Compassionate Communication and to work with this incredible team in the Center for Ethics. I'd like to take just a few minutes to share with you all one example of the type of work we'll be doing in the program in Compassionate Communication. And I want to do that by sharing the story of a patient. And before I do that, I'd like to share just one statistic with you, which is that in the United States, amongst English-speaking adults over the age of 65, almost 60% of that population has low health literacy skills. So what does that mean? Well, health literacy is our ability to get health information, think about it rationally to make decisions, and then understand it and be able to act on it. And it turns out that 60% of our older adult population struggles with health information on a regular basis. Now, the rest of us are also at risk for not understanding the health information we're receiving. And I can certainly relate into that, and I imagine many of you can, that anytime we're feeling sick, we're in pain, if we're feeling worried or scared, or we haven't slept well, our cognitive processing skills go down and our health literacy skills go down too. And that makes it hard to understand health information and recall it later when we need it the most. So let me tell you a story about a patient here. And I'm going to share some slides with you so you can follow along. This is David Green. He's 67, Portlander. He is recently retired. He was out walking his dog and slipped on some wet leaves, fell and hurt his hip. And he wasn't able to walk, so they took him to the emergency department where they did x-rays and they found that he had broken his hip. So he was put in the hospital with the plan to do surgery the next day. And in fact, surgery went great. He did fine, came out of it, was able to get up on his feet with the use of a walker and was able to move around. And by the third day, he was ready to go home. Now, when you've been in the hospital and you're getting ready to leave the hospital, you're going to get a stack of papers that we call a discharge summary. And I want to show you I'll read to you a couple of the sentences from the beginning of his discharge summary. It said, you were admitted with a right non-displaced femoral neck fracture following ground level fall and went to the OR on 2/12/18 for pinning. Physical therapy was started on post-op day 1. You were started on apixaban to prevent blood clots. And it goes on to tell us some more things that happened and things that he needs to do to take care of this. Now, there's a lot of language in here that's really unnecessarily complicated, and that can be confusing or create stumbling blocks for people. So I've just highlighted a few of the terms here. And if we think about terms like non-displaced femoral neck fracture, which is technically correct, that is his diagnosis, but is that helpful to him to have that going home? He referred to his problem as a broken hip. And why wouldn't we want to just say that in his written summary? We're notorious for using abbreviations and shorthand. In this case, the term OR refers to operating room. We should spell those out to reduce any ambiguity. The term pinning here is a type of medical jargon that really would only be used by surgeons to describe a variety of different types of surgeries used to fix a broken hip. and it probably doesn't help him here. We could have said more about what had happened, like they put some metal screws in to hold the bones together so that they could heal. Now, he heard some other messages, and he and his wife internalized some other messages during their hospital time as well. And one of those was that they understood that he should be taking blood thinning medications until he was up and walking. Now, that information did come to him, but it was delivered in a very different context. And so he, in fact, was prescribed a blood thinner when he was discharged from the hospital. Here's the prescription label. It's a medication called Eliquis. It said to take 1 tablet by mouth twice a day to prevent thromboembolism. Now, a couple problems. First of all, the name on the prescription label is Eliquis, but you remember in his discharge summary, it said the medication was called apixaban. Nowhere does it say that these two names are the same drug. So that's a potential area for confusion. Then here on the prescription label, it says to prevent thromboembolism, which is a term that he's not familiar with. In the discharge summary, it said he would be taking a medication to prevent blood clots. But again, it didn't say anywhere in any of this that blood clots and thromboembolism are essentially the same thing. And then lastly, the intention of the doctor prescribing this medicine was that he was going to take it for 30 days after he left the hospital, because that's the period of time when a person who's had hip surgery is at risk for developing blood clots in their legs. Now, remember, he and his wife, though, had heard the message that he could stop as soon as he was walking. So he got home and he's up and he's walking, and so he stopped taking his blood thinners. And unfortunately, after a short few days, he started to develop signs and symptoms. And in fact, he did get a blood clot in his leg. And now he's forced with the situation of having to take this blood thinning medication for 90 days to allow his body time to heal this blood clot and to prevent it from breaking loose and floating up through his veins up into his lungs, which could be very dangerous. So we can just see from this one case and this one example that there's opportunities that were missed here that really center on communication. We can see from this case that really all of us are vulnerable to miscommunications and misunderstandings when it comes to our healthcare. Older adults, perhaps more so than others. I've been focusing here on health literacy, but compassionate communication involves so much more than that. We have tremendous opportunity to improve empowerment through better communication. And that's why I'm so excited to be a part of this groundbreaking work. I'll leave you with that. Thank you for your attention. I hope you enjoy the rest of the program, and I hope that we get to do this in person one day soon. Thank you.
Thank you, Dr. Coleman, for helping us better understand just how important health literacy is to the patient experience. Joining the conversation are his colleagues, Dr. Katie Stowers, the Ronald W. Nato Director in Serious Illness Education, and Dr. Tyler Tate, Director of Professionalism and Comfort Care, supported by the Miles J. Edwards Endowment. They are going to share their reflections on the unimaginable challenges facing everyone in healthcare and the lessons they have learned over the past 18 months that they are going to carry forward in their roles as clinicians and teachers at OHSU.
Tyler, I think we'd all agree that this has been like a year and a half like no other. And I know my world's been rocked, especially clinically and just the way we practice medicine. And I was curious, I don't live in the pediatric side of things. I'm curious how things have changed.
I'm a palliative care doctor, and a lot of what we do is trying to sort of help families navigate really difficult and complex sort of emotional courses of illness. And so doing that, for instance, behind masks is really hard, and it's hard to connect with people, and it's hard to establish trust and rapport. So that's been a major difficulty. I think as many of us know as well, there is massive burnout occurring across the country and across the world. Nurses, respiratory therapists, physicians, social workers, everyone feeling under-supported and really under threat from COVID-19. And so navigating that has been extremely challenging, and feeling like, when everything is falling apart, how do we clinicians stay strong and stable for both our colleagues and our patients? It's been really tough.
I remember the feeling and the difficulty of being able to show empathy without the physical touch. We were coming up with creative ways like elbow bumps and head nods to be able to show, like the handshake or the hug that we would normally do. And so that, and like, as you were talking about behind the mask, but just the lack of physical touch has been really challenging too.
Something we here in the center have done is make a big pivot toward virtual learning, virtual education. I think that is mirrored in the clinical sphere of trying to do a lot more virtual visits. We do probably, 10 times the number of virtual visits that we used to do. It's challenging. There are different kinds of challenges, showing empathy, care, love, camaraderie with patients when you're both masked and gowned, and when they start crying, how do you put your hand on their shoulder, or do you give them a hug? Do you maintain that sort of sacrosanct 6 feet of distance? And that's paralleled and mirrored in some of the challenges I think we have had doing virtual communication, both with patients and for teaching. So I think we've had to really learn a lot about how to do that well, which is something that you've really been championing over the last year and a half.
I remember feeling so anxious to throw off my mask and actually be able to sit and have some of these tougher conversations virtually with some of my patients, because then I didn't have the mask and those, the shield and all of the pieces that were blocking me from the human interaction. But then I had to learn this new skill set of my default of sitting in silence or leaning out and touching a leg, or something that I would do to hold space for the emotion that was happening didn't work as well virtually. And so I had to rethink, like, how do I show that I'm caring and I'm listening? And it's not just that the computer's freezing, that it's something I'm actually doing intentionally. So really kind of going back to the bare bones of like, what did reaching out and touching their leg, what was that trying to show? And then coming up with some way that I could verbalize that or demonstrate that verbally. And I heard someone call it narrating the silence.
You're doing an enormous amount of educational work here through the Center for Ethics, helping cultivate improved communication skills for clinicians across the board, for medical students. Again, with this global pandemic really hamstringing our ability to be in person and develop those skills, how have you seen your work in communication, both sort of hit obstacles, but also overcome those obstacles? What have been some of the real bright spots for you?
What we've been able to accomplish from the educational side of things over the past year and a half, I kind of see a silver lining around COVID in a way. Just the fact that I can bring people from all over the state or all over the country together to learn with very little time, energy, expense invested is pretty fantastic. What about you, Tyler? What sort of things have you seen?
The various programs that I run, sort of, for instance, our course for the first year medical students called Living with Life-Threatening Illness, which we had completely virtual last year. And I will say that in this virtual course, we still created incredible connections, both between faculty and students and between students and their patient teachers. I think that in many ways, it created an even more intimate and sort of powerful environment.
Coming out of the pandemic, what kind of things are you excited for?
There's a lot of things that the Center for Ethics is doing in the future that I'm quite excited about. I guess if I had to pick one, I have been working to revamp what was formerly known as the bioethics study group. We've revamped it and now are rolling out something that's going to be called the Oregon Bioethics Colloquium. It's going to be a lecture series where we bring together scholars from across the Pacific Northwest and across the state to deliver academic talks that touch on all sorts of dimensions of medicine and health and the humanities and what it means to be human. How do we think about justice in a post-COVID world, and what are we doing with our medical technologies? How do we navigate end-of-life care in a world where our technology allows us to, do all sorts of things to bodies? So there's a lot of major questions that are addressed in this lecture series.
Again, I guess thinking silver lining of the pandemic for someone who's interested in teaching people communication skills, the pandemic has taught us in a really hard way how important compassionate communication is. And there really is a renewed interest, a pretty intense renewed interest in people, not only to improve their own communication skills, but to teach it to others. And so there's been a lot of interest for the programming that we're developing, and a lot of new collaborators who have come together. And it's really exciting to kind of jump on this wave of excitement and pull people on board and see where this new excitement will take us.
Next, we'll hear from 3 faculty members describing their experience in learning how to have skillful conversations with seriously ill patients and their families through the Vital Talk training program.
Vital Talk is a serious illness communication program that really turns the magic of communication into tangible skills that we can all identify and work on to get better. It really has given me these tangible things to help translate this medical world and all this mumbo jumbo into a common language where we can all be patient-centered.
When I first heard about it, I thought to myself, this is the tool that I need in order to become a better communicator. And as a surgeon, it's not innate. You don't know how to do an operation to take out an appendix. When we have these challenging conversations with families, it's a skill that's learned. No one is innately proficient at it. There is clearly a gap in the United States. There's a gap worldwide on how to have these conversations.
In my field, radiation oncology, there is just a dearth of education in how to do this appropriately. And I think a lot of our trainees, myself included when I was training, had some fear about engaging patients in these difficult conversations. I've certainly heard patients complain that I feel like I'm a cog in the machine. I'm just getting funneled through the infusion center and through my treatments.
It allows us to have a richer conversation. It allows us to get to the meaning behind a lot of what we say. There's a lot of medical jargon that is used, especially in the work that I do, that my colleagues do in the intensive care unit. It's a very complex arena. And for families who are really there to just be with their loved one, it can become really overwhelming.
Fascinating thing about Vital Talk is you watch your instructors and it seems like they have the magic touch and they just gracefully will their ways through. But I think through this course, they broke down what they were doing and what they were thinking in every moment. And it's actually very practical what you're doing.
Vital Talk has changed me as a physician in that it's really given me a name for the things that I do. So I can label it, name it, and focus on ways to get better at each of those skills.
I want to make certain that every single clinician that's taking care of a patient in any of our ICUs is armed with that skill that they can really provide optimal patient care. And it's the whole person, it's the person, it's the family, so that we really can support them as best we can. And then our hope is that they then go on to become facilitators and educators and then teach the next generation, and then it's self-perpetuating.
You've heard from our faculty, and now you'll hear from 3 medical students who have taken the Living with Life-Threatening Illness class. Students who participate in this class consistently rank it as the best academic experience they've had in either college or medical school.
The Living with Life-Threatening Illness course is a chance for students who are just in the thick of all the transition to medical school to be able to take a step back and remember that the reason they went into medicine is to interact with these patients and to have the opportunity to have raw and trusting relationships with others.
It's a very powerful course that really forces you to think about the important things and the scary things about being a medical practitioner, the things that we don't, talk about in lecture.
This class has really taught me that medicine is first and foremost an experience of humans and flourishing in love, and not a scientific endeavor with humans as a subject. And I think this course is going to remind me of that in those moments where you're looking at labs and values and disease processes, and to take a step back and realize that first and foremost, it's an experience of humans with an underpinning of science, not an experience of science using humans as the subject.
I think the most important things that I learned from the course is that working with patients isn't about thinking about a snapshot in time. Their life continues on and it has a past and a future, so does yours.
It's really important to have physicians and healthcare providers that understand that even if it's just another day and a job for you, it's some of the most vulnerable moments for patients and transformative, and that it's an honor that you're invited to witness some of the things that are happening in those conversations.
Sometimes we forget how powerful our words can be in the way that we deliver news to patients, and how much our own ego is wrapped up in that. Because if we're uncomfortable giving certain news, our patient is going to be uncomfortable. But it's really about them. And you owe it to them to be as honest as possible, but also as compassionate.
Living with Life-Threatening Illness course is transformative. And the reason I say that is there's almost this craving in medicine, or recognition, that we need to teach medical students how to be compassionate. And it's really hard to do. This course really got at the heart of how to do that, which isn't through, lectures and through tests. It's through experiences and through just kind of letting students lead their own experiences with real patients. The only recommendation I had at the end of the class is that more students should be able to take it.
Dr. Susan Toll, who has been the center's director since its founding 32 years ago, will now share the center's vision for expanding its work to meet the many challenges of the future.
I am so proud of all that the Center for Ethics in Healthcare has accomplished, and all that my colleagues are doing to move our programs forward. The pandemic has highlighted that we really have some areas that need more work, particularly in the program and compassionate communication. I'd like to share a personal story to demonstrate the need. It's my sister Margie. 26 years ago, Margie had a liver transplant. She's been on medications that make her more susceptible to infections and thin her bones, but protect her liver from rejection. She has arthritis in her knees. It got worse, and she went and saw an orthopedist. He did an X-ray and told her, "Your arthritis is advanced in your right knee, and if you weren't at risk for infections in the joint, I would operate on the knee and give you a knee replacement. But I don't recommend it for you. The risk of infection is too high." And he told her she had a subcondylar fracture, and that a brace might help her some, and that she should see her primary care provider about the pain that was keeping her awake at night. She went home using a walker, sleeping on her couch, unable to go upstairs to her bedroom, walking as little as possible, believing that that's what you did if you had a broken bone. She was needing more and more help, laundry, dishes, cooking. She was on a downward spiral. Fortunately for Margie, the principles of the program in compassionate communication provided her a different path. What Katie Stowers teaches about being curious about the person, what matters most to them as things change. Margie is a botanist. She cares about plants and her garden. She wanted to be independent, and she wanted to not have pain at night. She also benefited from what Dr. Coleman teaches about clear language and explaining things in ways that empower patients. She learned that a subcondylar fracture is not a broken bone like a ski accident. It's more like bone crumbling, and that with her arthritis, she needed to keep moving. It would be best if she were exercising almost every day in a pool, and if she left her house and her beloved garden because there are too many stairs. She bought a one-level condo on the 16th floor with just the right lighting for her plants and an eastern view. Within 2 weeks, going regularly to the pool, she was no longer using a walker and no longer needing narcotics at night for pain. It will take months for her to regain her strength, but she wanted me to share her story because she didn't want anyone else to suffer and potentially be in that downward spiral without the guidance she received to be able to be empowered and independent. We are not reducing anything as we expand the program in compassionate communication. Dr. Stowers continues to test all of the graduating medical students, and we tutor those who are struggling. She continues to expand the number of faculty that she is teaching to become instructors in serious illness education, and has recently completed the training of another 20. Dr. Tate continues to innovate in living with life-threatening illness, and in all of the outreach programs we have across our state, thanks to the support from the Kinsman Foundation. We have not compromised any of our principles. One of our original founders, Gary Kyoto, says it so well. The Center for Ethics in Healthcare does not accept gifts from healthcare industry sources, never has, never will. It is vitally important to the PULSE program that there be a completely independent process of decision-making without influence on the choices people make. To preserve our integrity, we're excited to announce that Bill and Helen Jo Witzel have established an endowment in ethics. We have other areas where we need to grow in moral courage and professionalism. We've had a transition in the Center for Ethics. We conducted a national recruitment for the next Madeline Brill Nelson Chair in Ethics Education, and are hiring Dr. Maureen Kelly from the University of Oxford. She's an outstanding educator. She's a mentor of other teachers, and she will help us grow our research ethics program. I am so grateful to every one of you for your support of the program. It is amazing to get up every morning and do this important work. We face some new challenges. The isms in healthcare have become so much more clear during the pandemic. Ableism, how we support, honor, and empower people with disabilities. Ageism. I think some of Margie's story is about ageism. There is much work to be done, and I have exciting news. The Storms Family Foundation has made a major investment, another grant. This will launch Rely, resilience, and empowerment in later years. This program will help address so much of what's in Margie's story and all the others who have stories like her. I welcome Liz Arrington of the OHSU Foundation to join me in expressing our gratitude.
Thank you to all of our donors. 96% of the center's work is made possible by private donors. They share our vision for healthcare that is more empowering and more compassionate. If you would like to learn more about our mission and how to make a gift to the Center for Ethics, we would love to hear from you. Thank you for joining us.